there's tremendous uncertainty in this modeling, in anybody's model, and part of that is you have to make estimates around human behavior. Very hard to really understand what human behavior would be in. It's likely that if a place like New York, if someone is ignoring the orders that are given, and then because you don't know anybody that's sick, and suddenly you know someone who's sick, and then you know someone who's very sick, and then you know someone who dies, then you might start to take it more seriously. So there could be, again, a lagging effect of human nature before it becomes very real to them. You know, we don't change the restrictions or the orders, but compliance may increase over time when people start to actually know somebody who has been affected by this. And so human behavior drives rate of spread. All these models have got a factor in there for rate of spread. There's nothing in these models about places like North Dakota, where if this is one of the last places in the United States for it to reach, will we take advantage of the extra time we had to learn and look what other states have done, and will we change our behavior accordingly? Or will we presume that, hey, because it isn't here yet, it's not going to come here, and then we'll continue to ignore orders that will, hasten if they ignore things that would, and do activities that would hasten the spread, or will we actually be smart enough to utilize our lead time to change the behavior? So tremendous uncertainty. So if you ask me about the two numbers I'm about ready to spit out, what's my level? I'll say very low confidence in the two numbers. But there's been some desire to have some estimates. And so we're at 100 cases today. When we look ahead, 94 cases today. When we look ahead about 3 weeks, the estimates in our models today would range from a 6x increase to a 13x increase, so that we're doing some planning that we might have 600 positive cases tested or 1,300 positive cases. Those are a range that we're looking in. It's possible we could come in under that if suddenly we become the most compliant state and are the most effective at all the guidance that we've given, or we could top that on the worst case scenario if things change. And again, as I said at the outset, these models are dependent actually on more inputs. We've only got 94 inputs to put in there, so this is the earliest I've wanted to share any kind of estimates at all, and these models will get better over time. Every state that's further into their crisis, their modeling has gotten better, so we can learn from them. But what we can do when we're planning for hospital capacity is talk about two things. We can look at other countries and know, in other states, and know that if you have 80% of the people generally that don't require hospitalization, 20% do require hospitalization. Of those 20% that require hospitalization, about a quarter of them, or 5% of the total, would require some kind of intensive care treatment. And so that's where we're really putting our focus, because we got to make sure that that's where we could end up with a shortage. We could have plenty of beds, but if we don't have we need more than beds. We also need equipment, which means PPE and ventilators in particular, and we need staff, including trained staff. If we have enough beds, equipment, and staff to reach the worst case scenario peaks, then that's when we're going to actually save lives. As we've said before, that if you ICU with proper care with a ventilator, sometimes the mortality rate can drop to be less than 10% than those people that would not have those same support mechanisms. So we've got a great team of people working on this. Major General Alan Dorman, who's our Adjutant General, who also leads emergency service, is our emergency services for the state of North Dakota. As part of our unified command, we've got a team that's working on surge planning. He's going to come up and walk through some of the numbers of our Tier 1, Tier 2, Tier 3 hospital planning. General Dorman.
Thank you, Governor. I'll just start out by saying we've been actively planning on our surge hospital capability since earlier this week. Our partners on this are the U.S. Army Corps of Engineers, the university system, and our hospitals throughout the state of North Dakota that have some surge capacity. Some definitions up front, or some information. First of all, you're going to hear some big numbers here, but this is a pandemic. We haven't had one of these in a very long time. The governor's talked every day about the latent data. So when you hear these numbers, we are planning against the worst case scenario. And that's what we're planning toward, hoping that we don't need it. But right now, that's what we need to plan to, just because the uncertainty of a pandemic, the modeling piece, which when we spoke with Vermont today, they said, you know what, you got to get to 100 cases before the models really start to give some level of fidelity. So again, we're planning against the worst case scenario. Some background and terminology: North Dakota has 55 hospitals. That includes the State Hospital of Jamestown, the VA Hospital in Fargo, and 2 Indian Health Service hospitals in Bottineau and Newtown. Our hospital capacity varies greatly. Some hospitals are licensed up to 6 beds, some to 315. Each hospital can expand. Expansion, again, depends on available staff, equipment, and supplies. When we talk about expanding, hospitals right now would be considered operating at Tier 1 level. In North Dakota, at a Tier 1 level, we have licensed, or hospitals are licensed for 3,378 beds. Included in that are 183 intensive care beds. But at a Tier 1, because of probably staffing issues, we have the capacity right now to man and provide the equipment and the PPE required, 2,098 beds. So that's the Tier 1 capacity for our hospitals. At Tier 2, our hospitals are still in the lead. But in Tier 2, they can surge and add another 296 beds statewide. That would bring us up to a total of 2,394. With additional help from the state cash for medical resources, personal protective equipment, and personnel, that Tier 2 surge could go to 4,759 beds. Tier 3 is what we're focusing on right now. This is when the hospital-led solutions with state support in Tier 2 are potentially exhausted. Right now in Tier 3, we are planning to add additional 4,000 beds statewide. Right now, the focus on Tier 3 is building a facility or standing up facility in Bismarck and in Fargo. The Corps of Engineers will be in here early next week to start the assessment process to go through university system properties right now. The one thing we like about the university system is if you use an existing dormitory, the infrastructure is there for some of the other things you need, like food service, and the maintenance staff is already there. So that makes the most sense looking at those university facilities when we go to a Tier 3 surge. The one thing I want to mention too, ventilators get brought up a lot. As we've drilled down even deeper on where all the ventilators are, whether they're in an operating room, in an ICU, or in a cache. Right now, our total count for ventilators in the state of North Dakota is 408. And we are working very closely with our Department of Commerce. I can tell you daily conversations with the Department of Commerce, turning over every stone, shaking every tree, trying to find any available personal protective equipment or ventilators so that we have the resources we need at Tier 1, 2, and especially if we ever have to get to Tier 3. The other thing I would just like to, and this has been brought up before, but at Tier 3, personnel is going to become a challenge. And there are retired healthcare or professionals or healthcare professionals that have maybe moved on to something else. We talked about this last week. Get in contact with your former employer if you're interested in coming in and being part of the team. If you have a skill and you don't know who to contact, call the Department of Emergency Services, and we will get you on a list with your skill set. If licenses need to be renewed or something needs to be waived under one of the governor's executive orders, we'll get after that. But we need to collect a pool or form a pool of human resources so that as these new requirements come online, we're not scrambling to find the people, the equipment, or the personal protection equipment that the people need. So I think that's it. They made me go off a script this time because I said some words last time I probably shouldn't have. So with that, I'll turn it over to the governor.